Hello and welcome to my YouTube channel. Continuing our series of surgical emergencies which we have been covering in my channel, today we are going to discuss one very important topic, and that is deep vein thrombosis. This is one complication which can occur in any post-surgical patient or even in a pre-op patient, especially in a high-risk cases. Identifying this condition early and treating it with the due diligence would lead to preventing of further complications. So without wasting further time, we would delve into more detail about deep vein thrombosis. I would be covering this topic especially in under the following heads: anatomy of the deep venous system, which is very essential to understand what exactly is deep vein thrombosis; pathophysiology; the risk factors and classification of deep vein thrombosis; the clinical features and different scoring systems which we use clinically for deep vein thrombosis; investigations, diagnosis, and the latest anticoagulation protocols 2024 modification we will discuss; and finally surgical and interventional radiological management as well as complications and the management of DVT. So without wasting further time, let's see what exactly is deep vein thrombosis. As the name suggests, deep vein thrombosis is the formation of a thrombus within the deep venous system, and this occurs most commonly in the lower limb. Now if you remember, the lower limb has both superficial as well as deep venous system, and this name is given. That means the veins which lie superficial to the deep fascia of the limb would be labeled as superficial veins, whereas the veins which lies deeper to the deep fascia of the lower limb would be labeled as deep veins, and mostly the thrombosis would occur within these deep veins. Now we'll go on. When we see the anatomy of the lower limbs, you would understand by the meaning of what exactly are the deep veins of the lower limbs. Now, incidence of deep vein thrombosis world over has been estimated to be about 1 to 2 cases per thousand per year. If it is a proximal deep vein thrombosis, that means if it is occurring in the veins above the knee, then this carries a very high embolic risk as compared to a distal DVT. That means the deep vein thrombosis occurring in the calf veins. Here, the, the risk of embolism is slightly less as compared to the proximal DVT. Now, deep vein thrombosis plus associated with pulmonary embolism is one of the most common vascular disease and mortality of a untreated pulmonary embolism, which is a complication of deep vein thrombosis, is as high as 30%. Now, this diagram would tell you exactly what we mean by deep veins. So, if we see here, mostly if we see in the anterior view, there is a dorsal venous arch. This dorsal venous arch empties generally into the superficial venous system. Whereas if you see the plantar venous arch, which contains the lateral and the medial plantar veins, this basically fuses to form posterior tibial and fibular veins. Posterior tibial and fibular veins, which are the part of deep venous system. That means they lie deeper to the deep fascia of the limb. So this posterior tibial and fibular veins, as it goes posterior to the thigh, posterior to the calf, it is joined by anterior tibial vein. Generally, the veins of the lower limbs, especially the deep venous system, goes and corresponds to the arteries. And sometimes these arteries and veins lie together in a common vascular sheath. And because of this, the blood is also pumped towards the heart by the arterial pulsations, which aids in the pumping of the venous blood towards the heart. So this posterior tibial vein, fibular vein, and the anterior tibial vein joins just behind the popliteal fossa to form the popliteal vein. This popliteal vein generally accompanies the popliteal artery, and it enters into the thigh in the adductor canal, and once it enters into the thigh, then it becomes a femoral vein. A femoral vein. Now, as a femoral vein goes up, it also gives one very important branch, and that is a deep femoral or profunda vein, which basically accompanies the deep femoral artery or profunda femoris artery. Now, as the femoral vein continues, it is joined by the superficial venous system. That means the great saphenous vein would empty into the femoral vein. Now, this femoral vein enters behind the inguinal ligament to go into the lower part of the abdomen, and then it becomes a external iliac vein. So that means if you see in this anterior diagram, as the femoral vein crosses behind the anterior inguinal ligament, it becomes a external iliac vein. So just to recapitulate, mainly the dorsal venous arch forms the superficial venous system, whereas the plantar arch, which basically consists of lateral and medial plantar veins, fuses to join and take part in the formation of deep veins, where we have a posterior tibial and fibular veins and anterior tibial vein, which are joining in the calf to form popliteal vein. Popliteal vein, once it enters into the thigh, it becomes a femoral vein. Femoral vein also gives a very important branch, and that is a profunda femoris or deep femoral vein. And once it crosses the inguinal ligament, it becomes the external iliac vein, which ultimately drains into the common iliac vein. So this in nutshell is the anatomy of the deep venous system of the lower limb. And just to recapitulate what we have been talking, in this slide you can see there are few things which you should concentrate on, and that is which we have already discussed, that any deep vein thrombosis affecting the proximal veins, that means popliteal and above, carries a very high chance of pulmonary embolism to the tune of almost 50%. Whereas the distal, that means the calf veins, that means below the popliteal deep vein thrombosis, the the pulmonary embolism risk is very less as compared to proximal DVT. It carries only 2% risk as opposed to almost 50% in proximal DVT. Proximal extension occurs in 15 to 20% of calf DVT, which should also be kept in mind. So if you see a patient with calf DVT, there is a 15 to 20% chance then it may extend proximally to involve the proximal veins. Inferior vena cava thrombosis would lead to bilateral deep vein thrombosis, also associated with abdominal pain. There are certain points which should be remembered, that the valves of the veins are the most common sites of thrombus initiation. That means at the valves of the veins, there is maximum is a place where the site of thrombus initiation occurs. Femoral vein generally lies medial to the femoral artery in the femoral triangle. That means if we have to find the location of the femoral vein, then palpate the femoral artery and the vein would lie medial to that pulsation of femoral artery. Popliteal vein generally lies posterior to the popliteal artery, and the perforators or communicating veins connect the superficial with the deep venous system. Now, coming to the pathophysiology of deep vein thrombosis, uh, I think this is a well-known triad which goes by the name of Virchow's triad or Virchow's triad, where the three important parameters or predisposing factors would lead to development of deep vein thrombosis. The first and foremost is a hypercoagulability or hypercoagulable state, which can be inherited or acquired. Now, what are the inherited hypercoagulable states? We have a prothrombin gene mutation, protein C and protein S deficiency, or antithrombin 3 deficiency. Now, these congenital conditions would lead to hypercoagulable state, leading to increased predisposition to deep vein thrombosis. There are certain acquired conditions which leads to hypercoagulable state, and amongst the most common acquired condition is malignant condition or any malignancy, which may lead to hypercoagulability, and this is known as Trousseau's sign. Trousseau's sign. Similarly, chronic use of oral contraceptive pills or hormone replacement therapy in a postmenopausal women may also predispose to hypocoagulability, and increased chances of DVT. Pregnancy, being a physiological condition, would also lead, as well as antiphospholipid syndrome. Post surgical state, especially if the patient is not ambulated early, because post operative state or post surgical state is also, there is an increased procoagulant mediators release, so it increases the chances of hypercoagulability. And on top of that, if the patient already has other risk factors like immobilization which is prolonged, then these patients are at risk of development of DVT. Heparin-induced thrombocytopenia or HIT is also one of the conditions which predisposes to development of DVT. The second component of Virchow's triad is stasis of blood flow. Now, this stasis of blood flow can occur because of prolonged immobility, like prolonged bed rest, say post surgery, or even patients who are bedridden because of certain conditions. Similarly, long haul flights of more than 6 hours has been documented to increase the risk of deep vein thrombosis. That's why it is always advisable in long haul flights to keep moving around, maybe take a walk through the aisle, and also do certain calf exercises and toe exercises while sitting, as well as keep hydrated. Chronic venous insufficiency, obesity, congestive cardiac failure, polycythemia vera, and post-op immobilization would all lead to stasis of blood flow and also development of deep vein thrombosis. The third component of Virchow's triad is endothelial injury. Endothelial injury can occur because of trauma. It can also occur because of fracture, especially hip fracture, knee fractures, or tibial fractures. Any previous history of deep vein thrombosis would predispose the patient for further development of deep vein thrombosis. How DVT can predispose? DVT, because of the fibrosis, causes the damage of venous valves. This also increases the risk of the venous insufficiency, as well as there may also be a residual thrombus which may propagate and cause further episodes of deep vein thrombosis. Any intravenous catheters or peripherally inserted central catheter lines, PICC lines, also predisposes to development of deep vein thrombosis. Certain vasculitis, homocystinemia, and any surgical vessel handling during surgery may also predispose to deep vein thrombosis. So these three components of Virchow's triad would increase the risk of deep vein thrombosis. All these three components interact and ultimately it leads to development of deep vein thrombosis, and clot may propagate. Clot propagation is one of the important factors which leads to higher risk of pulmonary embolization. Now, what are the risk factors for deep vein thrombosis, which is very essential to understand? So, immediate preventive measures can be done in such cases. The first and foremost is the surgical or trauma. Major orthopedic surgeries, especially total knee replacement, total hip replacement, carries a significant risk of deep vein thrombosis to the tune of almost 40 to 60%. Similarly, abdominal or pelvic surgery, any gynecological surgeries, neurosurgeries, any lower limb fractures and spinal cord injuries, all these surgical as well as trauma cases would increase the risk for development of DVT. Patient factors. Any patient who is elderly and more than 60 years of age, high BMI of more than 30, so obesity and age are important risk factors. Pregnancy and puerperium are another important risk factors for development of uh, deep vein thrombosis. Similarly, we have varicose veins, and prior history of deep vein thrombosis, as we have discussed, would also predispose to the patient to development of deep vein thrombosis. Similarly, dehydration and smoking also increases the chances of development of DVT. Certain comorbid conditions or medical conditions which we have seen, like active malignancy leading to Trousseau's sign, where there is a 15% chance of embolism, cardiac failure or myocardial infarction, nephrotic syndrome, polycythemia and myeloproliferative disorders, as well as sepsis from whatever cause would predispose to development of DVT. Certain drugs like oral contraceptive pills, especially the third generation, taken over a prolonged period, hormone replacement therapy, again taken for a chronic treatment for a patient of postmenopausal syndrome, patients on tamoxifen, erythropoietin, or any chemotherapeutic drugs like asparaginase would predispose to development of DVT. Certain congenital factors we have already seen, like protein C or S deficiency, antithrombin 3 syndrome, or more commonly prothrombin mutation. And then certain catheters or devices like central venous catheters, peripherally inserted central lines like PICC lines, especially for upper limb DVT, pacemaker leads, inferior vena cava filters, and temporary pacing wires. All of these are the risk factors for development of deep vein thrombosis. Now, what are the clinical features of deep vein thrombosis? Pain and tenderness, calf pain along the medial thigh, which is aggravated by walking, is a classical description of how a patient presents. So most of the patients would come to you with a swelling, which is unilateral, pitting edema, and the limb circumference difference would be more than 3 centimeters. So any patient with possible risk factors who comes to you with a unilateral swelling of the limb along with calf pain and medial thigh pain, which is aggravated by walking, and the patient describes that pain when they walk as a cramping, bursting type of pain, especially in the calf and medial thigh. And when you see the limb circumference, the discrepancy between the affected limb and the normal limb is more than 3 centimeter, then clinically DVT should be suspected and ruled out. There may be skin erythema and increased localized temperature over the DVT site. There may be dilated collateral superficial veins also seen in a setting of DVT. One sign which is classically described as a Homan sign, where there is a calf pain on dorsiflexion of the ankle, is a totally unreliable sign with only 45% sensitivity, and sometimes theoretically it may cause discomfort to the patient and also the chances of dislodgement of the thrombus. So this sign should be elicited with utmost care, and it may not be suitable in a very seriously ill patient. Similarly, the patient may also present with phlegmasia, which we'll see later on, which is a limb-threatening complication of deep vein thrombosis. Now, classically, a Wells score is used to assess whether the deep vein thrombosis is present or not. So, the Wells score consists of few criteria for which the points are given. If there is an active malignancy, 1 point is given. Any patient who is paralyzed or in a plaster cast immobilization is given 1 point. Any patient who is bedridden for more than 3 days or surgery undergone within last 4 weeks, again 1 point is given. Tenderness along the deep venous system is given 1 point. Entire leg is swollen is given another 1 point. Any calf swelling with more than 3 centimeter versus the other leg is given 1 point. Unilateral pitting edema on the symptomatic leg is given 1 point, and collateral superficial veins is given 1 point. So in total, if you total and if the score comes to less than 0, then this patient has very low probability of having a deep vein thrombosis. And in such a patient, a D-dimer test should be done. If the patient has a score of 1 to 2 on Wells score, then there's a moderate probability of this patient having a DVT. A D-dimer test with a color Doppler should be done. And if the score is more than or equal to 3 on Wells score, then there is a very high probability of this patient having a deep vein thrombosis, and in such a cases, urgent intervention should be done and immediate treatment should be started. Now, what are the investigations and diagnosis to be done in a patient who is suspected to be having a deep vein thrombosis? So, the one of the most important blood tests which we do is a D-dimer test. D-dimer is a fibrin degradation product. It has got a sensitivity of 95% and specificity of only 45%. It is used to exclude deep vein thrombosis in a patient of well score low or moderate probability. So if you have a patient and if you gave a well score on that patient, and if it comes out to be of a low or moderate probability, that means less than 0 or 1 to 2 score, then in such cases you would do a D-dimer to exclude the DVT, because in such cases the probability of that patient having DVT is low or moderate. In such cases you would do D-dimer test. The cutoff limit or cutoff range is 500 nanograms per ml, which is age adjusted. False positives can occur in pregnancy, any non-specific infections, malignancies, any post-op cases. That's why the specificity of D-dimer is only 45%. A negative D-dimer test and a low Wells score of 0 or 1, you can exclude deep vein thrombosis very, very safely. So the importance of D-dimer test is to exclude deep vein thrombosis in a patient whose Wells score is of low or moderate probability. That is the importance of doing this D-dimer test. The gold standard test for diagnosing deep vein thrombosis and the first line of imaging is Doppler ultrasonography or color Doppler, where we combine the Doppler along with B mode ultrasound. The sensitivity of Doppler ultrasound is for 94% for proximal DVT and only 64% for distal DVT. The most important sign is non-compressibility of the affected vein, which is diagnostic of deep vein thrombosis. You can also do a augmentation test where there is no flow increase with calf squeeze, which is suggestive of deep vein thrombosis. So this augmentation test can also be done. Now Doppler ultrasound can also very, very clearly identify the location of the thrombus. It can also identify the place and the site of the thrombus, the number of the thrombus, and it can also identify the age of the thrombus. If it is anechoic on uh, ultrasound, then possibly it's a fresh thrombus. If it is echogenic, then it is possibly a old thrombus. So that is the most important thing for Doppler ultrasound, which should be the first line of imaging. Now, another important test which we do is a CT venography or a magnetic resonance venography or MRV for short. CT venography is best done for pelvic or inferior vena cava thrombosis, which can be combined with a CT pulmonary angiogram, especially if you are suspecting pulmonary embolism. So the role of CT venography is best when you suspect pelvic or inferior vena cava thrombosis. Magnetic resonance venography is again a gold standard for pelvic and inferior vena cava DVT. And the advantage of MRV over CTV is that MRV has no radiation exposure as compared to CTV. A gadolinium enhanced MRV is generally done if Doppler ultrasound is inconclusive. So this is the importance of doing a CT venography or MRV, especially in proximal DVT of pelvic and IVC. There are other lab tests and special tests which should be done, like a baseline coagulation profile in the form of prothrombin time, activated prothrombin time, fibrinogen levels, and full blood count. Thrombophilia screen in the form of protein C and S factor 5 also. Screen for malignancy if there is an unprovoked DVT. Do a ECG, echocardiogram, and CT pulmonary angiogram if if pulmonary embolism is suspected, along with deep vein thrombosis. So these are the investigations which should be done in a patient with deep vein thrombosis. Now this diagram would show you, this is a picture of uh, uh, basically a color Doppler or a Doppler ultrasound, which shows on the left side, if you see, there is a visualization of the intraluminal thrombus, which is shown by this yellow arrow. Now, if you see this, this is classically looks like a Mickey Mouse sign, where we have a saphenofemoral junction and common femoral artery forming the two ears, and then we have the thrombus and the common femoral vein. So this Mickey Mouse sign is classically seen in a deep vein thrombosis on ultrasound Doppler. Inability to compress the vein completely is one of the classical hallmark signs on Doppler ultrasound in a patient with DVT. And this is CT angiogram, MR angiogram, which shows a site of deep vein thrombosis as shown. It is a proximal deep vein thrombosis. Now, DVT prophylaxis, risk stratification, and prevention of deep vein thrombosis. For risk stratification in a surgical patient, the classical scoring system which is used is Caprini risk scoring system. Caprini risk scoring system. Now this Caprini risk scoring system is a point-based system where the points are given for different criteria as shown in this diagram. And the criteria generally consist of age, any evidence of surgery, or swollen legs, or history of miscarriage or oral contraceptive for which 1 point is given. For for criteria like age more than 61 to 74, points 2 are given. So there are different criterias and different points. As the age increases, the points also increases. And in the last, maximum points are given if there is a stroke within 1 month previously, or a hip, pelvic, or leg fracture, or a spinal cord injury, for which 5 points are given. When you total this Caprini risk score, if it comes to be 0 to 1, then the risk level is very, very low. The risk level is very low, and recommended prophylaxis in such patient, you don't have to do any prophylaxis for DVT because the risk of development of DVT is very low in such patients. If it is 2, the Caprini score risk score is 2, then the risk level is low, and here you can use different types of uh, low molecular weight heparins. Similarly, 3 to 4 and more than 5. If the score is more than 5, then the risk level is very high. Here you have to use low molecular weight heparins and other IPC. IPC is intermittent pneumatic compression. So just to sum up, if the Caprini risk score is 0 to 1 based on the criterias and totaling, then the risk level of development of DVT is very low in this patient, and no recommended prophylaxis is advised for such a case. If the score is 2, then the risk level is very low, and then you can use intermittent pneumatic compression in such cases. If the Caprini risk score is 3 to 4, then the risk level of development of DVT is moderate, and in such cases we use low molecular weight heparin or intermittent pneumatic compression. And if the risk Caprini score is more than 5, then the risk level is very high for development of DVT. In such cases, we use low molecular weight heparin, plus you have to combine it with intermittent pneumatic compression. So for prophylaxis, we have mechanical prophylaxis, where the most commonly used mechanical prophylaxis is graduated compression stockings class 2. Why it is known as graduated or graded compression stocking? Because they exhibit different pressures at different levels in the limb. So the maximum pressure would be exerted towards the ankle, and as it goes up, the pressure drops towards the thigh. Normally the pressure would be about 15 to 20 millimeter of mercury. That is one of the most commonly used prophylactic measure in a patient who is had high risk of development of DVT, depending on Caprini risk scoring system. Intermittent, the second mechanical prophylaxis is intermittent pneumatic compression or IPC, which is one of the most effective mechanical ways of prevention of deep vein thrombosis in a high risk case. Early ambulation, needless to say, is one of the most important ways of preventing a deep vein thrombosis, and it's a cornerstone in a surgical patient who has just been operated. And foot impulse devices, which are IPC equivalent for orthopedic patients, can also be used. For pharmacological prophylaxis, the low molecular weight heparin like enoxaparin 40 milligrams subcutaneous once a day or 20 milligram once a day in a patient with chronic kidney disease can be used as a prophylactic agent, especially for patients who have got Caprini risk score of 3 to 4, that is moderate, or high, that is more than 5. Unfractionated heparin UFH can be used in the dose of 5,000 units subcutaneously twice a day or thrice a day. Then we can also use fondaparinux 2.5 milligram once a day subcutaneous, especially in orthopedic agents. Direct oral anticoagulants, that is rivaroxaban or apixaban, can be used as a prophylaxis, and warfarin, which is a vitamin K antagonist, to keep the INR range of 2 to 3. Now it is less preferred as a pharmacological prophylactic agent. The most commonly used pharmacological prophylactic agents still are low molecular weight heparin, which is one of the preferred drugs, and also now more and more direct acting anticoagulants can be used for prophylaxis, pharmacological prophylaxis. This is a IPC or intermittent pneumatic compression. This device is commonly used for Caprini risk, which is moderate or high risk. Now, anticoagulant treatment, the latest protocol, which is a 2024 protocol for for the established case of deep vein thrombosis. So, the drug of choice in 2024 protocol recommendation is direct oral anticoagulants. DOAC, direct oral anticoagulants, should be used as a first line drug, and the dosages are and the drugs are rivaroxaban 15 milligram twice a day for 3 weeks, apixaban 10 milligram twice a day for 7 days. You can also use endoxaban after 5 to 10 days parenteral. So these are the direct oral anticoagulants which should be used in an established case of deep vein thrombosis. The duration of these direct oral anticoagulants are 3 months for a provoked DVT, that means any surgery or a transient risk. 3 to 6 months for unprovoked proximal DVT, which is a first episode. It should be given for more than 6 months if there is a recurrent deep vein thrombosis or malignancies, and it should be given indefinitely if there are recurrent unprovoked deep vein thrombosis or in patients with thrombophilia. Parenteral anticoagulation, where direct oral anticoagulants are unsuitable, can be used, and amongst the parenteral anticoagulants, the most common is low molecular weight heparin, enoxaparin, 1 milligram per kg body weight, given twice a day subcutaneously. It is also preferred in malignancies and in pregnancy. Unfractionated heparin IV infusion, weight based, monitor the activated prothrombin time and keep it 1.5 to 2.5 times the control. Fondaparinux 7.5 milligram OD subcutaneously can be given, and renal dose adjustment is required in such cases. In pregnancy, low molecular weight heparin should be given throughout. Generally, warfarin or DOSCs are not recommended. So this is one very special situation. Cancer associated pulmonary VTE, we generally use direct oral anticoagulants. They are preferred over low molecular weight heparins. There are other ways of treating deep vein thrombosis. One is thrombolysis and certain interventional management. The first one is CDT or catheter directed thrombolysis. Catheter directed thrombolysis or CDT. Indication is iliofemoral DVT, that means a proximal DVT of less than 14 days duration, good functional status with low bleeding risk. So any patient who comes to you and who has been diagnosed with iliofemoral deep vein thrombosis of less than 14 days duration, they are the ideal candidates for catheter directed thrombolysis. And the commonly agent used is altiplase or recombinant tissue plasminogen activator in the dose of 0.01 to zero point zero 0.02 milligram per kg per hour. So altiplase has revolutionized the treatment of a deep vein thrombosis, especially in a proximal DVT through catheter directed thrombolysis. Monitor fibrinogen and stop catheter directed thrombolysis if the fibrinogen level drops to less than 100 milligrams per deciliter. Contraindications of catheter directed thrombolysis is any patient with active bleeding or any patient who has undergone recent surgery less than 10 days or any patient with intracranial disease should not be given catheter directed thrombolysis. We can also do pharmacomechanical thrombolysis, where it combines catheter directed thrombolysis along with certain mechanical disruption devices. So to take out the thrombus mechanically along with thrombolysis. So it combines both CDT as well as mechanically also you can remove the thrombus. What is the advantage of using this combination? It reduces the treatment time and less of thrombolytic agents are required. It is indicated, this combination treatment is indicated in massive iliofemoral deep vein thrombosis. Inferior vena cava filters can also be used, and the absolute indication of using an inferior vena cava filter is deep vein thrombosis in a patient where anticoagulation is contraindicated. That is the absolute indication of using an IVC filter. The second indication, absolute indication, is recurrent pulmonary embolism despite adequate anticoagulation. So if the patient has repeated episodes of pulmonary embolism despite giving an adequate amount of anticoagulant therapy, then such cases are ideal for IVC filters. Relative indications are any free floating thrombus, high bleeding risk where CDT or other agents may not be so useful, or a massive uh, pulmonary embolism patient who has survived. In such cases, IVC filter should be used. Retrievable filters are preferred over non-retrievable filters, and generally the filters are retrieved within 3 to 6 months. The complications can occur in IVC filters. It can itself undergo thrombosis and cause IVC thrombosis. It can cause fracture, filter fracture, or filter may also migrate. And the fourth modality of treatment for DVT is surgical thrombectomy, which is rarely performed nowadays because of advent of so many other modalities like CDT or combination with mechanical. Indications are only phlegmasia ceruleum dolens, which we will see in subsequent slides. And surgical thrombectomy is now less and less done. Now, just to recap here, anticoagulation alone is done for most of the cases, whether with direct acting oral anticoagulants or LMWH. Catheter directed thrombolysis or pharmacomechanical thrombolysis ideally is reserved for iliofemoral DVT of less than 14 days with a very high clot burden. In such cases, generally use CDT or pharmacomechanical thrombolysis. So this is a catheter-directed thrombolysis as shown in this diagram, where a catheter is inserted at the site of thrombus and the altipase or tissue plasminogen activator is given, which lyses the thrombus. Fibrinogen level should be monitored in such cases. And these are the IVC filters which can be inserted into the inferior vena cava in the patient with given indications. And this is a catheter mechanical thrombectomy where mechanically the thrombus can be broken into small pieces and removed, or it can also be sucked through a catheter aspiration thrombectomy. Now, there are DVT in special situations like in pregnancy. Incidence is about 1 in 1,000 pregnancies, and pulmonary embolism can be a leading cause of maternal death. Left leg is more common than right because of iliac compression by gravid uterus. Diagnosis is by uh, color Doppler ultrasound, MRV if iliac DVT is suspected. Treatment is low molecular weight heparin throughout the pregnancy and 6 weeks postpartum. The direct acting the direct oral anticoagulants and warfarin are contraindicated in pregnancy. DVT in malignancy, Trousseau syndrome, migratory thrombophlebitis with occult malignancy can be seen. Cancer associated or malignant associated DVT generally give low molecular weight heparin for 6 months, or DOAC can also be given. Avoid warfarin in active malignancies. IVC filter can be used if anticoagulation is contraindicated. Deep vein thrombosis after orthopedic surgery, for THR, DVT incidence is almost 40 to 60%, total hip replacement. And for TKR, total knee replacement, highest risk surgery for DVT. Prophylaxis always should be given with DOAC. So rivaroxaban 10 milligram OD for 5 weeks in THR or for 2 weeks in TKR should be given. Alternatively, apixaban 2.5 milligram BD can also be given. Mechanical and pharmacological combined can be given for highest risk. So in a nutshell, for orthopedic surgery, we use generally DOACs. For pregnancy, we mostly use LMWH, and DOACs are contraindicated. And in malignancy, you can use LMWH for 6 months or DOACs also. What are the complications? The most important complication is pulmonary embolism, and the typical clinical triad of pulmonary embolism, which is dyspnea, chest pain, and hemoptysis. Dyspnea, chest pain, and hemoptysis is rare and only seen in 25% of patients. The features of pulmonary embolism, which should be suspected in a known case of DVT, is tachycardia, tachypnea, hypoxia, pleuritic chest pain, sudden collapse, where massive pulmonary embolism can occur, right heart strain, Hampton's hump. Hampton's hump is nothing but a wedge-shaped infarct, which is seen as a wedge-shaped opacity on a chest X-ray, which is very rare. Diagnosis of pulmonary embolism is done by D-dimer with Wells pulmonary embolism score. The gold standard investigation which should be done in patient of pulmonary embolism is CT pulmonary angiography. VQ scan can also be done if CTPA is contraindicated. 30% pulmonary embolism if it is untreated, mortality, and massive pulmonary embolism has a very high mortality of almost 60 to 90%. How to manage a patient with pulmonary embolism? Low risk patients who are stable, give anticoagulation with DOACs. Intermediate to high based on Caprini risk scoring system, DOAC plus high dependency unit monitoring. And massive pulmonary embolism with shock, patient would require altiplase 100 milligram IV over 12 hours. Surgical embolectomy would be a last resort. So for low risk, anticoagulation with DOAC. For intermediate or high risk, DOAC and high dependency unit monitoring. Rescue thrombolysis if the patient deteriorates. And for massive pulmonary embolism with shock, catheter directed thrombolysis with Altiplase 100 milligram IV over 2 hours should be given. There is a pulmonary embolism severity index score known as simplified PESI score, PESI score, pulmonary embolism severity index score, which would tell you whether the patient with a pulmonary embolism is at low risk or as high risk of development of complications and what management should be done for such a patient. So the scoring system basically combines these 6 criteria for which 1 point is given for each: age more than 80 years, any evidence of malignancy, chronic cardiopulmonary disease, heart rate more than 110 beats per minute, systolic blood pressure less than 100 millimeter of mercury, and SpO2 less than 90%. If the score of simplified PESI is low 0, then this patient has got a low risk and patient can be managed as an outpatient. Any score more than or equal to 1 has got a high risk and increased mortality, and such patients should be admitted and managed accordingly. So this simplified PESI score, a pulmonary embolism severity index score, is commonly used in clinical setting to predict the 30-day mortality and also to plan treatment whether inpatient or as a outpatient. And lastly, we will come to another very important complication, and that is post-thrombotic syndrome and phlegmasia. What is post-thrombotic syndrome or PTS? The incidence is 20 to 40% after a DVT, and 4 to 10% of this may be severe. Generally, it occurs 6 months to 2 years following an episode of deep vein thrombosis. And the pathophysiology of post-thrombotic syndrome is valve destruction because of DVT, leading to venous hypertension and capillary leakage. There is a one scoring system which is used for post-thrombotic syndrome, and this goes by the name of Villalta score. The Villalta score has different criteria for which the points are given, as shown in this slide, like pain, cramps, heaviness, pruritus, paresthesia, hyperpigmentation, venous eczema, and the scores are added. If the score Villalta score is 5 to 14, then it signifies as a mild to moderate post-thrombotic syndrome. And if it is more than 15, that indicates a severe post-thrombotic syndrome. How to prevent post-thrombotic syndrome in a patient of DVT? Compression stockings with 30 to 40 milligram pressure should be prescribed for such patients for at least 2 years. And in any patient with proximal DVT, consider catheter-directed thrombolysis or a combination mechanical and pharmacological thrombolysis. Phlegmasia is another complication which basically consists of two components: phlegmasia alba dolens, which is commonly known as white leg. What happens is that in this, there is a massive iliofemoral deep vein thrombosis, and this leads to arterial spasm leading to reduced inflow, arterial inflow, and the limb becomes ischemic, white, cold, and painful. So any white, cold, painful leg in a patient with massive iliofemoral deep vein thrombosis would be labeled as phlegmasia alba, alba for white, dolens. Here there is no gangrene and arterial supply is intact. Management is generally with anticoagulation and limb elevation along with catheter directed thrombolysis or combination with mechanical thrombolysis. The other phlegmasia is phlegmasia caeruleus dolens, which goes by the name of blue leg. Here the venous outflow obstruction leads to cyanosis and the extremity becomes bluish black. It becomes bluish black in color, and these patients are at risk of development of venous gangrene if untreated, which can lead to a loss of the limb. It's an emergency. Immediate anticoagulation with catheter-directed thrombolysis or mechanical thrombectomy should be done. Such patients are also at a risk of development of compartment syndrome with increased pressure leading to ischemia, further aggravating the problem. So fasciotomy may be required in such cases. Fasciotomy would reduce the compartment pressure and prevent further complications. But this phlegmasia caeruleus dolens has got a very high mortality of almost 20 to 40%, and limb loss can go to the extent of 50% of patients who have established venous gangrene because of venous outflow obstruction. So these are the two complications which can occur: post thrombotic syndrome as well as phlegmasia, basically phlegmasia alba dolens and phlegmasia caeruleus dolens. So just for summarizing all this, what we have just discussed quickly: number one, Virchow's triad, hypocoagulability plus stasis plus endothelial injury is a core pathophysiology for development of DVT. Well scoring system: less than 0, low, 1 to 2, moderate, and more than 3 or equal to 3 of high probability of that patient having a DVT. D dimer is enough for low or moderate. First line diagnostic test is Doppler ultrasound, compression Doppler ultrasound, gold standard. D dimer can also be done to exclude DVT. D dimer is basically to exclude DVT. For treatment, direct oral anticoagulants are the first line, given for 3 months in a provoked DVT, 3 to 6 months in an unprovoked DVT, indefinite if the DVT is recurrent. Phlegmasia caeruleus is blue gangrenous leg. It is a surgical emergency. Immediate catheter-directed thrombolysis and fasciotomy should be done. Post-thrombotic syndrome can occur in a patient from 6 months to 2 years following development of DVT, can be prevented with class 2 compression stockings for 2 years. If the Villalta score of post-thrombotic patient is more than 15 or equal to 15, it indicates severe post-thrombotic syndrome, and such patients also have venous ulcers, which signifies worst outcome. Inferior vena cava filter is only used if anticoagulation therapy is absolutely contraindicated. Retrievable IVCs or filters are preferred, and it is generally not routinely done. Carcinoma DVT generally is treated with low molecular weight or DOAC preferred. For pregnancies, low molecular weight only given, no DOAC or warfarin. And for orthopedic surgeries or surgical patients, we can use DOAC or low molecular weight therapy for prophylaxis. With that, we come to the end of this topic. I hope you have liked this topic on deep vein thrombosis. And if you have liked, kindly share, subscribe, and share with your friends and colleagues. I would keep coming back with more and more topics. Thank you for watching my channel. Thank you for your time.